Good morning, everyone. Can you hear me okay? So we are so incredibly thrilled to be with you this morning. We've been looking forward to this session for some time, and you are in for a treat with our esteemed panelists, whom I will introduce shortly. But I just want to start by saying that we know that emergency medicine in developing countries focuses on providing timely, effective, and life-saving care resources. It's in developing specialty in many countries. And there's evidence that there needs to be solutions in all of these developing countries to ensure that the resources are there to provide timely care. We also know that there are still many challenges faced such as lack of mentorship, lack of equipment, and a lack of the adequate environment needed to care for patients effectively. And there's also, as we know, a lack of recognition of emergency medicine in many countries, particularly in developing countries. We know that delivery of emergency medicine emphasizes innovative solutions such as task shifting, community-based first responders, and low-cost technologies. So strengthening emergency medicine in these regions is really crucial to improving health outcomes, reducing preventable diseases and deaths, and enhancing resilience against public health emergencies like natural disasters and disease outbreak. You know, one of the things that I love so much about this ICEM and the conference is that we are globally coming together to band together and uphold emergency medicine, not just in our own countries, but really across the globe. And we know that now more than ever, developing countries need all of our hands on deck to ensure that the resources are there to develop them and allow them to thrive. And so it is my pleasure with that to open a discussion about 3 specific developing countries over the next several minutes. We're going to discuss Nepal, Belize, and Rwanda. So how many know much about those countries? You all know much about these countries? Okay, I see a few hands. Well, by the end of this session, we hope that you will know much about these countries. To start with, Belize, we know, is a beautiful country in Central America. It's known for its natural beauty. It actually has one of the largest jaguar sanctuaries in the world. And believe it or not, in Belize, there is apparently no fast food chains, because they lean on local culinary as well as fresh foods, which is amazing. And then we're going to talk a bit about Nepal. We know that Nepal is an amazing country in East Asia. It's landlocked and so surrounded by other countries and land. Nepal is definitely known for having 10 of the tallest mountains in the world in Nepal, including Mount Everest. And so much to learn about Nepal in terms of what they do there. It's the home of Buddha as well, and just so many amazing pieces about Nepal to learn. And then we talk about Rwanda. So Rwanda, known as the Land of Thousand Hills, is a small but captivating East African nation. It has several unique and very interesting facts about it. You know, it's one of the world's cleanest countries. In fact, they've banned all plastic bags and, in fact, have once a month a day where no one drives cars, apparently, in order to make sure that the environment stays clean. It also has a remarkable legacy of female representation in terms of leadership in that country, and it boasts a remarkable home in terms of engendered mountain gorillas that you can't find in many other places of the world. And so with that, I want to specifically introduce our panelists, and they will guide us through defining and developing emergency medicine in their respective countries. Our objectives, as you see here, are to discuss the history and the evolution of emergency medicine in these countries. We will no doubt talk about the challenges and opportunities relative to the practice of emergency medicine in these countries. We will highlight the role and the impact of emergency physician leadership by women in particular. If you haven't noticed, we're all women on this stage. And we'll also explore the development of academic emergency medicine in these countries, while discussing sustainable solutions in terms of an education framework. So with that, I'd like to introduce our first panelist, Dr. Olita Ship-Pakar. Dr. Ship-Pakar is an assistant professor and a consultant emergency physician in the Department of Emergency Medicine at Manharar Medical Campus, Institute of Medicine, Tribhuvan University Teaching Hospital in Kathmandu, Nepal. She is one of the first female emergency physicians in the history of Nepal to be trained in emergency medicine with a doctorate degree. She serves on the executive board of the Nepalese Society of Emergency Physicians, and she is a voting member of ICEM. She is a fellow of the Royal College of Physicians of Edinburgh, and she is associated with the World Health Organization Nepal, the Department of Health Services, and the Ministry of Health and Population, Government of Nepal, in numerous projects, including a leading role as an expert in the development of the first ever national document on standard treatment protocol of emergency health services. She is an American Heart Association certified BLS, ACLS, and PALS instructor, and is an IFEM accredited basic emergency care trainer. Her interest and experience in research marks her involvement in supervising randomized controlled trials being conducted by the Oxford University Clinical Research Unit of Nepal. A reflection of her keen interest in toxicological emergencies is shown by the work she is doing in the ED in order to manage multiple research projects related to toxicology. She has also co-authored numerous chapters with international authors and published textbooks on emergency medicine and pre-hospital care for medical doctors, nurses, and paramedics. And she is the recipient of the Academy for Women in Academic Emergency Medicine and Global Emergency Medicine Academy Award at the prestigious ICEM2025 annual meeting in Austin, Texas. She has also been awarded the Nepal Bidya Bhusan Padak A, the most prestigious literary award presented by conferred by the President of Nepal for her PhD degree in emergency medicine. Please welcome with me Dr. Ship-Pakar. And now I will introduce our next panelist, Dr. Lise Momparisi. She is an emergency medicine and critical care physician and a university lecturer. She was the head of the emergency department at King Faisal Hospital, Rwanda, and the chair of Department of Anesthesia, Critical Care, and Emergency Medicine at the School of Medicine and Pharmacy at University of Rwanda for 3 years. She then joined a 3-year fellowship in pediatric intensive care at Wolfson Medical Center in Israel, and where she currently is based. After completing the fellowship, she will return to Rwanda, where she will continue her clinical and academic roles. As one of the pioneers in the field, she is mandated to contribute to the growth and sustainability of pediatric emergency medicine and pediatric intensive care in her home country. She's interested in pediatric acute medicine and post-operative care of children with heart diseases. Her expertise as a COVID-19 focal point during the pandemic not only enriched her medical knowledge on the subject, but opened her eyes on the public health aspect as well as surge management in the practice of emergency medicine. Please welcome with me Dr. Momparisi. And our third panelist is Dr. Yenisi Cruz, who actually, due to a family emergency, was unable to be with us physically today. So Dr. Cruz will introduce herself on this video that she was so kind to create for us, wherein she will share with us and kick off the discussion around Belize and emergency medicine, specifically in Belize, relative to challenges and opportunities. And so in her physical absence, please give Dr. Cruz a hand as well.
Good morning, everyone. I hope you all have been enjoying Montreal and all the amazing experiences that ICEM2025 has brought to you. I am here today with these amazing ladies to talk about our stories. Olita is going to tell you about Nepal. Liz is going to talk to you about Rwanda. And I'm going to tell you a little bit about Belize. Belize is a very unique country because it's surrounded by Spanish speaking countries such as Mexico, Guatemala, and Honduras. Yet, we are an English speaking country and we're also considered part of the Caribbean community, even though we're not an island. However, we do have the Blue Hole dive. Welcome to come to Belize to try that. If you like history, we have Mayan culture and we're also known as a melting pot in the region. However, if you just like to lay on the beach, we also can offer you that. I can spend hours talking to you about Belize, but today we came here to talk about emergency medicine. I am proud to say that I am the first residency trained emergency specialist in Belize. That in itself did not come without its challenges. Belize does not have residency training programs. All the doctors that are here have studied abroad and then they come back home to practice. So, in order for us to further our training, we need to leave the country. I chose to go to Mexico, and I was trained at the Hospital General Dr. Manuel Gea Gonzalez. I finished residency in March 2020, and that in its own brought a whole bunch of new challenges. For 5 years, I was the only emergency specialist in the country. However, as of January this year, my friend and colleague finished his program in Guatemala City. Challenges do not come without opportunities. Being in Mexico City was a great opportunity for me. In 2018, ICEM was held in Mexico City while I was a resident, and I had the opportunity to attend. I was introduced there to the basic emergency care course and to the international world of emergency medicine. Basic emergency care seemed to be the perfect tool that I could use to start building emergency medicine in Belize. I knew I could not do it alone. However, I was fortunate enough to have a group of emergency medicine colleagues who supported me all along the way and up to today, not only with basic emergency care, but with all the tasks and projects that I have come up with in the past 5 years. And sometimes they come up with projects for me, but I appreciate every single help that they give. I can tell you that that group of colleagues have become my friends, and we have been able to implement the basic emergency care course along the country, not only at the National Referral Hospital, but we have trained people from every single hospital in the country. Not all of them, but we are trying. I cannot tell you that the path of training has been perfect and that everything went smooth without any troubles, because I would be lying to you. And I am almost sure that all of you have had the same troubles that I have had or similar ones. The lack of training, the lack of emergency medicine policies, the lack of knowledge about emergency medicine in the medical and nursing community are only some of the obstacles that I have met in the past 5 years. However, each one of these has shown up as an opportunity to be able to improve and grow. I have been trying to tackle some of these obstacles and some of these tasks one by one, sometimes all of them at the same time, in some occasions wearing many hats at the same time. It has not been an easy road, but I can tell you it has been fun It has been challenging, and it has been rewarding all along. A teacher cannot be a teacher without their students. An emergency medicine specialist cannot be one without a team. I can tell you that I have an amazing team. They're not perfect, and neither am I. They give me headaches, they give me tasks, they give me challenges every single day. But we also get the opportunity to grow every single day together. The training teams that I have in the country or along the country have been my biggest allies in spreading the word about emergency medicine care. And without them, the trainings that we've had would not be possible. This is just a little bit of the many things that I do, and this is a little bit about my story. I am grateful to have had the opportunity to share it with you today. I hope you continue enjoying Montreal and all that ICEM 2025 is bringing to you.
Again, we are so grateful for Dr. Cruz, despite having a family emergency at home, taking the time to share with us her world from Belize. And with that, we are going to transition to hearing about Nepal. Welcome to the stage, or to the podium rather, Dr. Shilpakar.
Thank you so much, Asia. So good morning, Montreal. A warm welcome and namaste from my country, Nepal. So I'm Dr. Olita Shilpakar. I'm an assistant professor working in the Department of Emergency Medicine in Tribhuvan University Teaching Hospital. I'm privileged to be here among all of you. So I come from a country, a beautiful country, a small country, situated in between Nepal, in between India and China. It is a beautiful country which has its rich cultural heritage. It has the mountains, including the world's tallest mountain, Mount Everest, and it's the birthplace of Lord Buddha. If I have to talk about the evolution of emergency medicine in Nepal, it is a developing specialty. It is evolving slowly but steadily. The doctorate of medicine in emergency medicine was started in 2011 with the help of, in collaboration with the Australasian College of Emergency Medicine. And we have 10 graduates till date. We have also been able to start a postgraduate program since the past 2 years. So we have 2 residents now. We also have fellowship in emergency medicine and a few doctors who have done this specialty from abroad and come back and have come back to work in Nepal. Other than that, we have general practitioners who are trained for a few months in emergency medicine, who are taking care of the emergencies in the country. But the emergency health services, if I have to tell you about the health services delivery in Nepal, we have tertiary care centers, we have referral center, just like the picture shown in the first picture, it's my hospital. We also have private sectors with even services like helicopter emergency medical services, the rescues are being done. But we also have provincial hospitals and the primary care centers where the emergency department is taken care of by the general practitioners or either the medical officers or even the paramedics in some parts of Nepal. Yes, we have challenges. This is the harsh reality of seeking emergency care. If you look at the first picture, there's overcrowding. This is a daily scenario of my hospital in the yellow area where we do not even have beds for the patients. So you can see 2 patients in 1 bed most of the time. The demand versus supply, we have never been able to meet that. It's always overcrowded, it's always overflowed with the patients. So this again is a scenario from the red area of my hospital. And if you look at the third picture, this is a picture from the rural area of Nepal where this particular container or particular bag, I should say, it's called doko in Nepali. We even use this as human ambulances. It's actually made for carrying firewood from the forest. But then we also use this for carrying patients. So you can imagine if there is a case of a trauma, a fall injury patient, if the patient has been carried in something like this, then what will be the result later, even if the patient goes to the referral centers, right? So the ground situation, it is kind of difficult for us to maintain the infrastructure in terms of human resource. We're still lagging equipments, the medications, academics, training, research, and even specific protocols for emergency. But we do have opportunities. We have been doing lots and lots of trainings for nurses, for the allied health professionals. The pre-hospital and the ambulance services are getting better nowadays. We have, in collaboration with the WHO, even technician trainings for the emergency services. Also, as I'm also keen in teaching, learning at the same time, and sharing knowledge, I take classes along with a few of my colleagues. We have had trainings for different groups of people, including the firefighters in the Trivandrum International Airport, the foreign exchange students in conferences, and so on. At a national level, the Constitution of Nepal says that no one shall be deprived of emergency health services. And as mentioned earlier, we have been able to come up with the first ever standard treatment protocol of emergency health services along with the government of Nepal, Ministry of Health and Population, and the collaboration with WHO. And I had the opportunity to be the team leader in this project. At an international arena, a few good things, including the award that I received at the prestigious ICEM2025, along with a few training in basic emergency care, training of the trainers. We also have AHS certified provider and instructor courses. We do not have to go anywhere else. It is there in the country itself these days, something to be happy about. But then there are challenges for female emergency physicians. No doubt, women leadership is growing steadily in the country. We had the first president of Nepal. In my institution, we had the first ever woman dean in the institution, and I'm one of the first emergency physicians in the history of Nepal to have a doctorate degree. But then, having said that, we still have gender-specific issues. We have lesser opportunities in terms of leadership, in terms of going to conferences, or in terms of leading a department. So that is something to think about. Pay scale is another issue. And I often get this, that this is a physically demanding subject. Why are you even into emergency medicine? It's not a woman's cup of tea. And with all due respect to all the nurses in the department and across the hospital, we are often addressed as the nurse in the emergency. That is a trend that you can see in Nepal. So I think the society is still hesitant to accept the change that is being developed. Again, challenges in emergency medicine academically, it's quite complex. The thing that we experienced while we started the residency program, maybe because of the lack of resources or the lack of even the recognition in the medical community that it is also a specialty, the lack of mentorship, and also the adequate environment. But then I am optimistic, as always. We have NSEP, that is the Nepalese Society for Emergency Physicians. It is a voting member of IFEM, and I'm in the board as well. We do have a bit of research that is going on. I'm particularly interested in the research. We have been doing research in quite a few subjects in terms of wearable devices, collaborating with the University of Oxford, also been doing a few RCTs here and there on stroke, toxicology, antimicrobial resistant studies, and so on. So if I have to mention the way forward, what is the way forward then? Maybe capacity building to strengthen partnerships. We need to increase the visibility of emergency medicine in the international arena, also by addressing barriers and bridge the gaps. The emergency medicine program should be expanded for sure, and strengthening of public health emergency policies in a country like ours, which is disaster prone. We are with the natural calamities, having earthquakes and floods every now and then. So enhancing the knowledge and network so that we can increase the goodwill of emergency medicine and also increase the quality of emergency care in the country. So if I am asked what is the future of emergency medicine in my country, I always say that it is quite promising, and I would like to compare the status of emergency medicine of my country with this picture, which I have taken recently. There are a few clouds here and there, but if you just look at the picture, the sunrise is really beautiful. So I'm really, really hopeful that these clouds will go away and we'll have a bright, sunny day, and the emergency medicine of the future of emergency medicine is quite promising for me. So thank you so much.
Excellent. And now for our final panelist, Dr. Mamparese, welcome to the podium.
Bonjour. I'm happy to be here to tell you about emergency medicine in Rwanda. Rwanda is a beautiful country in the East African region of Africa. It's known as Le Pays des Mille Collines, the country of 1,000 hills. It has very nice landscape, a lot of lakes, and it's one of the few places in the world where you will see mountain gorillas. Rwanda was completely destroyed in 1994 after the genocide against the Tutsi. But for the last 31 years, Rwanda has rebuilt, and it's now one of the safest countries in Africa. It's also one of the top one destination for tourism, and we are hosting a lot of international conferences. Maybe ICEM will come there sometime. I'm here to tell you about the health system in Rwanda, and particularly the emergency medicine practice in Rwanda. So the health system in Rwanda is a pyramid. 90% of health burden or disease are treated at the community level via the community health centers. And those health centers are mainly managed by nurses and also other people in the community that do surveillance for disease. They vaccinate children. If you are pregnant and you need to deliver, you will deliver in a health center where there will be experimented midwife and nurses. Doctors are at the district level, which is like somewhere in the middle of the pyramid. So they receive transfer from health centers for more sick patients, and the doctors in the district hospital will go to supervise each week the health centers. The practice of emergency medicine as a training for physicians started at the top of the pyramid in the teaching hospitals and the main referral hospitals in the country. So you understand that when you are giving training to emergency physicians, they are mostly seeing very sick patients who could not be treated at the community level. So the emergency medicine doctors are trained to treat very sick patients, but the scope of practice of emergency medicine is not only to save the very sick, it's also prevention, it's also disease surveillance so that we don't get many people to reach the top of the pyramid, because we also cannot have the capacity to treat it. So we are working on the access of emergency medicine up to the community level. The training of emergency medicine as a specialty started in 2012. It was in an initiative of a US-based organization called SIDHARTE that had a partnership with the Ministry of Health. So they chose the University Teaching Hospital of Kigali as a training center. And during the first 3 years, the mortality decreased significantly, and the Ministry of Health saw that there was a big change. So they immediately incorporated the emergency medicine as a full-term 4-year program, and it was owned by the University of Rwanda. The first cohort of emergency physicians were mentored through Human Resource for Health. So there was a specialist from developed country who came on ground for 4 years period, and they trained local physicians. I am blessed to be among the first cohort that was trained then. The first class graduated in 2018. I graduated in 2019. And in 2019, the Human Resource for Health phased out. So from the moment we graduated, we had the responsibility to train our younger colleagues and to perpetuate the practice and training of our fellow young colleagues. Currently, we have 28 emergency medicine specialists that have graduated from University of Rwanda. We have 15 residents that are from University of Rwanda, and this year a new university has opened up. It's the African Health Science University that has now 9 residents. So it's work in progress. But we cannot talk about emergency medicine without talking about pre-hospital care. You saw the pyramid. So any patient who cannot be managed at a lower acuity level hospital needs to be transferred to a higher acuity. But also, if you get sick in the community, you need to be transported to the hospital. So we have a pre-hospital system in the country since 2007. It's mainly a scoop and run program, and it's run mainly by nurses and non-physician anesthetists. It's quite effective. The challenge now is that there is no physician in the pre-hospital practice because, again, we are very short-staffed. In 2016, the Rwandan Emergency Care Association was created. It brings together all emergency care providers in the country, nurses, NPA, non-physician anesthetists, doctors, and everyone who is a stakeholder in the practice and delivery of emergency medicine in our country. We held our first conference back in 2016. And since then, we have been doing a lot of activities. We are teaching BEC courses and so on. The Rwandan EM community is connecting with the worldwide EM community. The residency program at University of Rwanda has initiated a training course that is called EMIT, Emergency Medicine in the Tropics, where we invite different people from developed countries to come and see the disease pattern that we have in the tropics, in Rwanda, and we will learn for them, but also they can learn some things for us. We have had the honor to host the AFCAM conference back in 2018, and last year in Botswana, we were happy to take our residents to the conference, and some of them won research prizes. So we are trying to stay connected, though we are challenged. And at home, we are creating homegrown solutions. We are teaching our young colleagues, and we are connecting with different partners through podcast training and so on. I have given you a very positive picture, but the practice of emergency medicine in Rwanda is not without challenge. As you saw, we are 28 physicians. Like myself, for the last 2 years, I've been abroad training in Tel Aviv, which means that the team that stays on ground to treat patients is very strained, and the demand is very, very high. Also, the settings are not optimal. Some centers are doing better than others, but mainly there is a big problem with congested emergency room. And whenever you see a congested emergency room, it tells a lot about the health system in the whole country, because they say it's a snapshot of the whole health care system. So we are still facing problem with congested emergency room. We are trying to install policies and procedures to try to cross the gap, but it's still a very big problem. Also, when we were growing up, you would see a specialist that has made it in life, and you will try to identify yourself to him. You'll be like, I want to be like this one when I grow up. But emergency medicine is a new specialty in our country, and it's harder to inspire young colleagues and to make them join our program. We are hoping that when we will be making more impact on ground, we will inspire more, and we will have more younger colleagues interested in the practice of emergency medicine. Especially that when we started, emergency physicians were not seen as specialists. They were seen like some senior GPs, but since the COVID-19 and the highlight of the need for emergency medicine, it has like the optic has changed, and emergency medicine is now very recognized. There is a lot of push from the government, from the Ministry of Health, to enroll more young doctors in the program, because during the pandemic and whenever we are faced with a challenge, recently we had a Marburg outbreak, emergency physicians and emergency nurses are at the front line, and they are closing the gap. Last year, fellowship programs have started. I am due to go back home and help initiate a PQ fellowship back home as well. And if you want a job, it's easier to get a lot of job in emergency and make money. So it's a good thing also to be an emergency physician. So what is it like to be a woman, a leader, and an emergency physician in Rwanda? In Rwanda, since long time, the value of the woman has been undeniable. Women are called mutima w'urugo, which means they are the heart of the home. The value is very, very much recognized, and it's also reflected in recent years with the highest representation of female in the Rwandan parliament. In the emergency department, I was the head of the department. I used to say that I wear too many hats. I'm the head of everything. So I was the head at the university and also in the top hospital in Rwanda. And when I went back to training, my colleague, Dr. Doris, took over. This is not undermining our male colleagues, but this is to highlight that at the work market, our value is equally recognized. And this is not saying that it's not without challenge. I am a mother of 2 young children. I rely a lot on the support from my husband, on the support of the system to make the homework, because we can go to practice medicine, but to run the daily life of a home, it relies still on the woman. So we really, really rely on the support from our partners, from our families, to make it work. So it's very challenging, but we are hopeful. Thank you.
Perfect. So let's have a little bit of Q&A for the last several minutes of our discussion, and we certainly want to open it up to you all should folks in the audience have any questions for our esteemed panelists as well. So I just want to kick it off by saying, you know, I am the immediate past president of ACEP, the American College of Emergency Physicians, and when traveling there, I was all over the country in the U.S. seeing various emergency docs, and one thing that I learned is that we have a lot of the same challenges, no matter where you go in the United States and certainly in the world. But I also learned that if you've seen one emergency department, you've seen one emergency department. And so to that end, I want to hear from you all in terms of what you think makes your country unique in terms of an opportunity to leverage that uniqueness. So what I'm speaking to are the challenges that your country faces in terms of emergency medicine development, and how might that challenge be unique enough to leverage it in a way that advances emergency medicine. I think it's on. I think it's already on.
Is it on?
It's already on.
It's on.
Yep. There you go.
Thank you, Aisha. The uniqueness, if I have to talk about my country, it's the uniqueness could be, it's just an emerging field for now, so that there are so many unexplored fields that we can discuss, we can work on. For example, let's say it is a disaster-prone country, we are having earthquakes, we had a huge one a few years back. So maybe we could work on the public health awareness and also the disaster preparedness so that it will strengthen, you know, the pre-hospital care and also a lot more in that regard. So,
Absolutely. Yeah. How about you, Dr. Lees?
Thank you. The Rwandan health system, as you saw, is a pyramid, which means that there's already an established health system where when you want to intervene, you will know what exactly you will need to do. If you are going to create a teaching program, for instance, at the health center, you will know that you will have to deal with nurses and what would be the expectation. So it will be easy to create training, to create training program, to create initiative, and to measure impact depending on what level of the pyramid you are at. So I see the Rwandan health system as an easy system to create impact and to measure outcome.
Yeah, absolutely. Good. Another question that I wanted to see what you all think about, and there are a couple folks who have questions from the floor, but just really quickly, I am curious as to if you have any thoughts around what other countries globally, how we can really join hands in terms of impacting and improving the delivery of emergency medicine in our countries. Is there anything specifically that we might do as a community to ensure the growth?
So I think the first and the foremost thing that is important in our context especially is that we need to be aware, or we need to promote that emergency medicine is a separate entity. It's a separate specialty. We are actually struggling with that at the moment. So maybe we could start from there and then take it from there onwards, and then do the collaborative work, the capacity building work that we are supposed to do. So yeah, maybe we should start from making everyone aware that it is a specialty.
Yeah,
So
perfect.
Thank you. I think about leveraging the voice of hidden heroes in the communities at the bottom of the pyramid, because those are the people who make impact, yet their work is sometimes not recognized. So I think if the whole community would leverage the voices of those people who are working in remote areas and recognize their work, it would be very, very much impactful.
Perfect, perfect. And even just having invitations to speak here, right, at ICEM in terms of spreading the great work that's being done in your respective countries. So let's go to the audience now for a couple questions we may have time for. I see the gentleman at the microphone.
Thank you. Actually, in follow-up to your comment about international systems, things being different, Dr. Cruz mentioned that all of you trained in different countries. She trained in Mexico City. At least, Dr. Muparezi is training in Israel. I apologize, Dr. Shulpakar, I didn't hear where you were trained. Can you talk about how training in a different system, how you can port those skills to your home environment where the system may be different? The medicine is easy, but the system may be what gets in the way. Can you talk about comparing those? Thank you.
I'm new in training. I was lucky to be trained in Tel Aviv, but the center I'm training in is bringing children from low-income countries to get treatment in Israel, mainly children with congenital heart disease. So I see a lot of children coming from low-income country and getting the best of the care, and I'm trained to bring that back home. So I think when I go back home, I am hoping to keep the mentorship from my supervisors, but having seen what could be achieved with the same type of patient I will face home, it will be helping me to bridge the gap.
Excellent. Anything to add?
yeah. So just to answer your question, I was trained in Nepal only. I joined the program after it was started in collaboration with the Australasian College of Emergency Medicine. So I consider myself lucky that I didn't have to go anywhere. I was trained in my country itself. But then having said that, to gain more people to influence or more young doctors to take up this specialty, it is again a challenge. So we are working towards it. We are making sure that the people who have been trained in Nepal, a couple of them are going out of the country because of maybe more opportunities outside of Nepal. So we are trying to make sure that that doesn't happen. We can retain the doctors, whoever have been trained in Nepal, they would stay in Nepal.
Excellent, thank you. One more question from the floor?
Thank you, Andrew Singer from Australia. We've had a lot of sort of positive talk about all the things that have worked in helping you, but I'm interested, have you had any offers of help from other countries that didn't work, and why?
So the question, just to repeat it, is have there been any initiatives from other countries in the region or otherwise, or other even societies that has not been so helpful anything to learn from in terms of lessons?
I've seen some initiative that took place even in my country, and it was wow in the beginning, but they didn't last, and mostly it was because of the investment, like we are like a low-income country and we don't have the funding. And whenever you get an external support that comes with everything Western, but there is no transfer of means, of knowledge, there is this gap. The moment the funding and the supporters are gone, everything crashes. I've seen it so many times. And
No, it's a great answer. I mean, I think it's about sustainability in a lot of ways in terms of making sure that these great ideas actually last. So, well, excellent. We have actually come to the end of our time. I want to thank our esteemed panelists again for your amazing contributions as emergency physicians, as women leaders in emergency medicine as well. I have to also thank Brittany, as well as Jennifer and the rest of the ICEM and IFEM staff and leadership for an amazing conference. Thank you all so much.